Hello and welcome. Welcome to Tech Tuesday. I'm Stacy Hyatt, member of the Tech Titans Board of Directors and a tri-chair for this Health Tech Forum. This is a relatively new platform for many of you and for us as well. So before we get started, I want to announce that if you're experiencing any problems using the Remo platform, see a link to the Remo facts in the chat. Tech Tuesday is a new programming concept designed by the Tech Titans, safeguarding a regular time to our experts discussing cutting-edge technologies. Mark your calendars for the second and the fourth Tuesdays of every month during the noon hour to enjoy an outstanding presentation very similar to what you're going to hear with us today. Whether it is Tech Tuesday, the Tech Industry Luncheon on the third Fridays of the month, or the work of our talent or innovations teams, or many other programs, Tech Titans continues its long-standing commitment to being a champion of the North Texas tech community. Information and registration for our events can be found on the website techtitans.org. Before we start discussing our presentation or introducing our keynote speaker, I want to review how you might ask questions during this presentation today. Again, a new program, so we're kind of all getting used to it. Look to the right of the main screen. You should see a box that has both a chat room that I mentioned a moment ago and a participants icon where you can check on who is attending today and a Q&A function. Please just use the Q&A function for your questions. Do not put them in the chat room. The questions will be posted to our speaker after he completes his presentation in the order they are asked. You may also vote on the question by emphasizing it's a more important question by clicking to the left of it to keep it at the top of the Q&A function. You might have a chance to look at that and weigh in there. Just a reminder one more time, if you have questions, we will not be monitoring the chat function for your question. It will only be in the Q&A section. The Health Tech Forum is pleased to have Dr. John Whyte, the Chief Medical Officer of WebMD, with us today. To introduce Dr. Whyte and moderate the Q&A session, please welcome one of the members of the Health Tech Forum and Vice President of Content at the Merit Group, Melissa Chadwick. Melissa?
Thank you so much, Stacy. Great to be here today. It's my great pleasure to welcome you to the Healthcare Forum today. I'm super excited to have Dr. John Whyte with us. He's, as Stacy mentioned, the Chief Medical Officer of WebMD. And in his role, Dr. Whyte's actually been leading efforts to develop and expand strategic partnerships that create meaningful change around important and timely public health issues. Some of you might be familiar with him from his COVID video series, which has been incredibly helpful for I know a lot of us who are out there with a lot of questions around this. And prior to WebMD, Whyte served as the Director of Professional Affairs and Stakeholder Engagement at the Center for Drug Evaluation Research at the U.S. Food and Drug Administration. Before this, nearly a decade as the Chief Medical Officer and Vice President, Health and Medical Education at Discovery Channel, which I know we all love. And at his work there, he developed, designed, and delivered educational programming appealing to both the medical and lay audience. So I know that I've also watched that with my family as well. And still a practicing doctor, he completed his internal medicine residency at Duke, as well as earned a Master's of Public Health and Health Policy and Management at Harvard University School of Public Health. And as I mentioned, he's a board-certified internist and continues to see patients in Washington and DC and Maryland. In this presentation today, we're going to talk about, how has COVID-19 really changed consumer expectations for health tech? I think we're all feeling this acutely right now at home, and we deal with this in our everyday lives. I mean, if you think about fitness trackers, remote patient monitoring, we're all kind of in this information overload when it comes to healthcare. All these changes we're experiencing have created friction and opportunity for innovators out there working on health technology and then on the consumer side as well. So Dr. Whyte's going to walk us a little bit through some of the challenges with the shifting consumer behavior, technology that's changing the landscape, and the impact of go-to-market strategies and much, much more. So with that long intro, a big welcome to Dr. Whyte to the Health Tech Forum.
Thank you, Melissa. I'm delighted to be with you today.
Great, great. Well, I guess I think one of the things I definitely want to start off with, keeping this as kind of a, fireside chat type forum, was, in Texas here, we're kind of coming out of the storm from last week. And, if COVID-19 wasn't bad enough, many of us were kind of confined to our homes and dealing with no power, plumbing issues and whatnot. So kind of thinking about this backdrop, to what degree are events like this almost an inflection point for how, when, and where people turn to for their medical advice and treatment?
No, absolutely. And I think it also reminds us that health isn't just about going to a doctor's office or having to go to the hospital. It's about these other aspects. It's about, electricity. It's about access to clean water. It's about, climate control, all the other elements that people are experiencing challenges with right now in Texas and some other areas. So I think it opens our eyes to the broader concept of health and wellness. And I think it also shows the importance of digital tools and online access. We see that in other areas in terms of the vaccine distribution, that if you're having challenges with online tools and resources, you can be left behind. So it's really an eye-opener to the role of tech, the role of health, the definition of health, and it reminds us that it can be fragile many times as well.
Absolutely. I think we're all feeling that a little bit right now. And I think with, how this is actually changing consumer behavior, you kind of mentioned, we're looking at different sources in different ways. I think we've all turned to, quote unquote, Dr. Google at some point. And I'd love to hear from you, especially with your perspective as Chief Medical Officer of WebMD, kind of some of the interesting behaviors you've maybe seen on the site as well, and how that's, evolved into, how you're looking at the data and services you're even providing as WebMD.
COVID has accelerated the changes that we started to see pre-COVID in terms of, we know what consumers want, whether it relates to healthcare or it relates to general retail. They want convenience. They want cost savings. They want control. So if you think about grocery shopping, how many of us have ordered online, picked it up at the curb or had it delivered? Some people are saying, why would they ever go grocery shopping again? Who's going to the stores now when you can order everything online and on Amazon? And that gives you that sense of control. It allows you to be convenient and you can shop around for cost. That's not going to be unique to retail. That's also how healthcare is going as well. And what we've seen with the COVID pandemic is that most care for a period of time shifted almost completely to telehealth. 80% of visits in April and May of last year were telehealth visits. That compares, Melissa, to 2% in January of last year. That's what the baseline was. Right now it's about 40%, depending upon the specialty, but no one's going to go back to 2%. Why drive 30 to 40 minutes or take, public transportation and wait another 40 minutes for a 10-minute visit? You're not going to do that anymore. Expectations have permanently changed. And what we see at WebMD is, and this was happening pre-COVID, you search for content, but then you want to do something about it. The days, if any listeners remember when you print things out and you'd hand it to your doctor of what you read online and get his or her opinion. You have your own opinion by the time you come in, if you come in. And the shift, what we're talking about, is really moving from you search content and now you want to connect it to care. And you want to do it right now. So if you were searching knee pain last night, Melissa, or any listeners, what do you want to do? You don't want to wait till the morning to call your doctor's office and be on hold. You want to do a telemedicine appointment right then. Or you want to be able to order a test if you're having some symptoms. And in many states, you can order lab tests directly. So that's what we're trying to address at WebMD, is changing consumer expectations, which were already happening, but now are supercharged. And how do we change this search for content into care? And, in COVID, it's been a lot about anxiety. Anxiety and anxiety-related medications is 7 times in terms of search what it was before COVID. as it is in COVID. So, we really have to figure out ways, how do we help provide people tools to address some of the mental health issues of the pandemic?
Right, right. And I think the point that particularly resonates with me is this desire to have information and do something about it pretty immediately. And I think maybe some other folks can relate out there. I'm a new mom, so I'm nervous about everything. I want data. I want to know, if my baby's crying, why, what is it? And one of the first things I did was go out and buy a smart sock and a camera. Yeah. And I soon found that maybe it's too much of a good thing. All of these devices I have in the house, all these things are all collecting data. So when you think about innovation in the health tech space, I kind of wonder what your perspective is on what's the right balance. So between complete data overload, not knowing what to act on, versus not enough to have an informed decision or trigger that next healthcare action. So I'm kind of curious what your perspective is on that.
Well, two things I have to say first, as other people would probably say, and congratulations on your new baby. But as you move to your second or third, you won't be worried. Something fell on the floor. It's okay. and you'll have to tell us, what's the smart sock? I don't know that one. What is that?
Yeah, it's actually a device that goes on the baby's foot, and it basically monitors oxygen levels, heartbeat, all those things, and will actually trigger an alert if some of the levels go beyond a certain threshold. The only problem is sometimes you get false alerts and things like that. So in the middle of the night, heart attack when it's just the sock happened to come loose or something like that. So that's kind of the too much information sometimes part of it.
That's the perfect issue with all the wearables that we have, our sensors, our trackers, our remote patient monitoring, all of which is progress in terms of being able, again, to have control of our care and to have data. But the challenge is there's data overload. We talk about, big data, real world evidence. I spent many years, as you pointed out, the U.S. Food and Drug Administration. How do we use real world evidence? How do we collect that? Now we have the ability to do that. The year before, in terms of CES, was all about sleep. And it wasn't just, sensors that, we put on our wrist or our finger. I mean, it was actually pajamas that can give you information, kind of like that sock, or even the bed itself. So what I'm interested in is, what do we do with this collection of data? And the challenge is, what I want as a doctor is some assessment of that data, right? I don't want you to come in with your sleep scores and different graphs of your weight and everything. I kind of want it what it happens with glucose control in terms of, some of the patches and sensors is it collects the data, it gives some type of analysis, and it provides maybe even a preliminary diagnosis. The challenge with a lot of the consumer products, Melissa, is that once it starts to do analysis and make some impression of diagnosis, it becomes a medical device by FDA. And most people don't want to go through that process of becoming a medical device, which can be very expensive. So I think where we have the rub is we have all this data, but then how are we going to analyze it and collect it? So how do I use it as a physician? How does a patient use it in terms of how do you interpret all this information? And the issue, back to the smartwatch and back to, the Apple Watch, is the issue of atrial fibrillation in terms of, it's great that I can diagnose it in patients that may not have known it. But roughly 20 to 30% of those are false diagnoses. They don't actually have AFib, or it was very brief in time and they don't need treatment. So what are the additional costs for that? So it's going to be iterative, but this is where I think is going to be some of the biggest advancements in tech, especially relating to health. What are you going to do with all of this data? How are you going to analyze it? How are you going to package it in a way that I, as a consumer, can use better, or I, as a physician, am going to be able to base clinical decision making on? Because right now, the problem is it's all unstructured. Nobody wants unstructured data. Somebody has to take the time, or there has to be machine learning or AI to help process that for us. And we're not there yet. That's where we're going to see the biggest advances and the biggest winners as well, because we're really going to move from just give me more and more data.
Mm-hmm. And you say that we're not quite there yet. What do you think will kind of get us through those barriers? I'm thinking about risk and things like that. My husband is a podiatrist, and I was talking to him about this chat, and one of the first things he talked to me about was security. You know, I can't do anything with personal data, anything like that. That's, you know, that's his first consideration with anything when it comes to healthcare technology. So I'm curious where we stand in kind of the evolution of protecting and making that a part of the whole process of development.
I think it's a big concern about data privacy. And here's one of the best examples, very practical and real life right now. So with COVID, we've had a big issue with contact tracing. There aren't enough contact tracers, especially given the amount of, you know, cases that have been there. So let's be honest, tech has come forward saying we can use our phone, use Bluetooth technology to identify who you've been in touch with and in close contact with. And I could send you a note if someone that you came close to has been the adoption of this technology. Abysmal in the single digits. It doesn't work unless you get 60 to 70% to participate. Even in Singapore, which has different privacy issues, was only at 15%. And I'll be honest, I keep getting an alert from Google, do I want to, you know, participate contact tracing? And, you know, I got the vaccine, so I'm like, well, I don't need to do that. But also I do have reservations about it, as most people. So I think privacy is a huge issue that we see the real life consequences that for whatever reason, people don't want to know, don't want to make available who I've come into contact with. But, you know, it's the other issues around that as well. And I think some of it is going to be the regulatory flexibility of what's called the Center for Devices and Radiologic Health, CRH at FDA. The drug side is called CDER, the Center for Drugs. The device side is called the Center for Devices and Radiologic Health. And they actually regulate software. So they're not regulating the device per se. They'll talk about its device agnostic. But the software that's used to make some interpretation, that's where I think is going to be perhaps a bottleneck. And a lot of innovation is going to be driven in terms of what's the regulatory environment. And you talk about risk, it's the risk in terms of evaluating risks as consumers, but it's also the risk of tech innovators of how much they're willing to take to market a device, a tool, software that's going to help make some interpretations. I mean, it's the same way when you think about all these genetic tests and saliva tests that people have taken, and you can take one to say, you know, what's the best exercise for you? What's the best, you know, type of foods for you? They give you some assessment and interpretation. Otherwise, why would you do that if you just got back a report? So it's going to be interesting to see how devices and tech iterate to use information in a productive way for consumers, and when it relates to health professionals, because everyone just can't rely, you know, on Dr. Google or WebMD. And we say that we're not trying to replace your physician, we're trying to promote more effective discussion. So we can easily be overloaded by data, and where innovators have to take the lead is how are we going to structure this data? How are we going to make it more practical?
Mm-hmm. Yeah, and that's really interesting. And you mentioned that earlier, that step between, you know, gathering the information and having a trigger to a point of care. How do you see that working when you think about the whole healthcare ecosystem? You have obviously the payer, the patient, all these different components. You know, who's going to pay for these things? How's it going to be covered? What is that going to look like in terms of a model that might be sustainable for moving forward?
I think for tech, my impression would be they're more interested in a B2B business than a B2C business. So to sell all these tools and resources to patients, it would be even better if I could get insurers to pay for it, if I could get companies to pay for it to help improve my overall care. But I think COVID is also changing things, that we're going to be less focused on glitz and more focused on what are the practical outcomes. What's going to change my diabetes care? What's going to change my heart disease? Unless, you know, there are these fancy lasers that I could identify you from afar by your heart rhythm, right? So to use it for security, whatever. Is that going to be more important, or what I've been talking about is this technology, this tool that you would put, not making this up, on top of your toilets. And it would monitor your urine literally every single time if you use the same toilet, in terms of whether or not you may have ketones, which may indicate, diabetes or prediabetes. It might be able to tell if you have a UTI. It'll analyze your stool for blood, which could be hemorrhoids or colorectal cancer. This is true preventive medicine. This is true. The patient is in control. That's literally every day. That's what we're going to see more of. There's tools about that you can put this device on your tooth that could manage the pH in your stomach and your mouth and start to tell other aspects. So that's where I think we're going to see more development in terms of tech, less glitz in terms of what's really cool technology and what's going to focus outcomes, what's going to help my disease do better, or true prevention, like the toilet. I'm telling you, that is going to change healthcare in some ways.
That's amazing to think of. Yeah, I mean, you think of technology, the smart home of the future, and how that's going to integrate with your healthcare. That's pretty amazing. And I guess to your point too, in terms of how this will get rolled out. I know Humana just last week announced kind of the solution for home health, RPM, telehealth services, kind of a package for chronic care. So it's interesting to see how, from the insurance side, how they're going to start, taking what they've learned from COVID and try to build solutions to kind of also be a part of this ecosystem of care and facilitate some of these things. But to that point with COVID, have you seen any new avenues of, it all comes down to healthcare innovation and money, where's the source of funding for a lot of this innovation? Have you seen any new pockets of, areas where people who are innovating can use some of those funds to help develop their technologies?
Yeah. I haven't seen as much of the use of those funds just because, as you know, it's a very difficult market right now. But to your point to Humana, it shows you again what the trends are that you need to be aware of, where it's really the patients being more controlled. It's really what we've been calling this idea of patient centricity. In the past, the market always focused on physicians. If you didn't have the physicians in a healthcare tool, it was going to be very hard, to make money. But now we're truly shifting it, partly accelerated by COVID, to consumers. And we're seeing more and more care in the home. So that's why we're seeing these remote patient monitoring in the home. So you don't have to come in to the doctor's office. We're talking about doing clinical trials in the home, and the FDA has issued guidance in terms of regulatory flexibility. We're giving cancer care, cancer treatment in homes in some areas where we never thought that was possible before. And if you actually took out the indirect costs of the physical infrastructure of hospitals, you could provide probably the same type of care, even high-level care in people's homes. That would be less because you're not counting for the cost of having these big institutions. And I think we're going to see a trend towards, are you going to build this big ambulatory center in your town? Or are you going to focus more on digital innovation that's going to allow care to be delivered more in the home at a patient's convenience at lower cost while they're in control? That's where we're going to see dollars going to. And we have to be realistic. We're going to have limited resources in a post-COVID world.
Absolutely. And I think a question came in that I think is very relevant to the funding question here also is a question on the technologies have been in existence for literally years, yet the business of medicine, third-party patient billing has blocked this. One of the questions asked, do you see this? Do you see a more fundamental change in the industry happening?
I do, and I think that's for telehealth. Let's be honest. The reason why telehealth didn't work is you didn't pay doctors enough. Why would I be willing? I would not be able to survive in practice if I'm only getting $10 per patient visit, even if I'm doing it, telemedicine. And I'll tell you, I have done telemedicine visits, telephone visits. It still takes the same amount of time. I got to review the chart. I got to have a good conversation. In some ways, it can take me longer to get to where we need to be in evaluation, and then I need to document my notes. It's not a 2-minute visit. So when we had payment parity, right? So pay the same amount for virtual or in person, that's also how we saw it skyrocket. And that's why we're going to see it continue. But if all of a sudden we say they're not equivalent and we're going to pay less, you're not going to have that. So it is the reality. There needs to be financing for these types of services. So I do think it matters a lot. And the other way I'll say on regulatory flexibility, I've written this down. There were 53 new drugs approved last year by FDA during the middle of a pandemic, but they're primarily focused on COVID. And that was the second highest in 20 years. So, we're seeing innovation on the drug side. We need to see more innovation on the device side. And I think the challenge is, in terms of digital tools, as the person points out, we automatically have funding on the drug side. Insurers are going to pay for it. And on the device side, if it's a business to consumer initiative, it can be tricky, and there's a price point. But think about what Walmart is doing in terms of their impact on health and opening up centers, right? And they're also focused on customer service. If I asked you, Melissa, a couple of years ago, would you go to Walmart for your healthcare? You would probably say, why would I go to Walmart? And now if I asked you, would you go to Walmart? You might say, I prefer to go to Walmart. I can get my pet care, I can have x-rays, I can buy, toilet paper and get everything done in one-stop shopping. So I think that's where we really need to think how, back to this idea, the focus has to be on the patient, the consumer. And that's going to drive where we choose our tools. And then what's the payment mechanism? Is it a third-party payer like insurer, which that would be ideal, but then that relies on outcomes and measures and how are you changing clinical care, and not just glitz or this seems really cool or look what I can measure. And that's what I think changes the mind shift. But that takes a lot more investment too, to do the clinical trial, to show outcomes, and even in remote patient monitoring. When it first started in heart failure, costs actually increased at the VA because people now saw that their symptoms were getting worse and they needed to go in. So short-term costs increase, but long-term costs decrease and better quality of life.
Mm-hmm. Fantastic. Yeah, so trying to change gears back to the data side of the conversation, we actually have a couple questions coming in here as well. Someone was asking about medical institutions adapting and learning using machine learning. And I think this all goes back to the big data question of how do we actually change this data into outcomes. And I think there was a question earlier too about false positives and how that comes into the equation as well. So I want to bring those two up.
So in machine learning and AI, where we've seen the greatest advances in diagnostic imaging, x-rays. So and there's been studies on this. If I show you a human eye, even ophthalmologists can only tell 50% of the time, by chance, whether it's a male eye or a female eye. I don't know if it really matters, but AI can tell you 99% of the time accurately, whether it's a male eye or a female eye, looking for all of these different patterns. We can see 20 different patterns. AI and machine learning can look at 20,000. So it makes sense that it works on imaging. Many of you know the story of IBM Watson in terms of oncology, where they were not able to predict with greater, accuracy the right chemotherapeutic regimen versus, oncologists. So I think on machine learning and AI, sometimes when you say that to physicians, they think EHR. Meaning, you know what? You told me EHR was going to make my life easier. It hasn't. Now you're telling me AI and machine learning is going to make my life easier. And it may or may not. Part of where people fail in the health technology space in AI and machine learning, they don't think about the workforce issue and the generational issues. So are people going to be able to use this technology? The FDA has talked about this. Are you making clear how your algorithms are determined? Could there be racial bias just by virtue of, we see that in skin cancer? Most imaging for skin cancer has been based on Caucasians. So how do we know that your model is going to accurately diagnose it in people of color? I think that's where the future is, and we've talked about that, but it has to be focused, as we talked about, the practical. It needs to be transparent as much as one can with intellectual property, how your algorithm is designed, and then we have to think about the workforce issues. How does it fit in terms of my management of a disease or condition. That's where I think we're going to see more focus in terms of AI and machine learning. And we've seen lots of areas when it's deployed in hospitals and it hasn't had adoption, because if you don't tell the clinicians and others how it works and be more transparent, they're going to be a little suspect. They're not going to be as sure. Radiology is a great example. I think we need to take it to other areas. And we're starting to see that in terms of, as it makes sense, cancer screening, which is a lot of imaging, a lot around testing. So we have a little bit of a way to go, but that's definitely a pocket of innovation.
Absolutely. And as you're speaking, and you just mentioned EHRs, I'm kind of wondering, with all of these different tools, all these different devices, collecting data, how does that make it to the actual physician that you're going to hopefully eventually see about whatever condition is occurring?
I mean, we've been talking about interoperability
Yeah.
for 10 years. So if you come see me, and even if you bring me, you know, somehow people want to show me the stuff on their phone, there's no way I can incorporate it in the medical record, right? So my only alternative is, am I going to write all that down and transcribe it into the medical record? Let's be realistic. In a 20-minute visit, 12-minute visit, most people aren't going to do that. So we have to have a way that you package that data and allow me to use it in the medical record. And continuous glucose monitors and some of that have done that. It's the same world in the regulatory process. We talk a lot about patient-reported outcomes, what's clinically meaningful to patients. So at FDA, it has to be packaged in data points that are part of the new drug application. If it's not packaged in a way that a regulator uses, or a physician uses, or consumer uses, it's not going to work. So we have to have that interoperability, which has been a challenge for much too long. And we did see some flexibility around that, you know, early on in the pandemic. So remember, for telemedicine, you wouldn't be able to use many of the technologies we've been using, Zoom, FaceTime, Skype, and we just had to be more realistic and practical. It goes back to the issue of privacy, but it's a balance.
Absolutely. Yeah, I know one of the questions was about fast healthcare interoperability resources, FHIR. So that kind of gives a good kind of response to that one, I think, unless there was something else you wanted to add.
Well, you'd asked about the false positive results too, or false negatives. You know, let's be realistic. No test is 100% accurate. Too often, though, we design a test, it gets clearance perhaps, or even approval from the FDA, but then we broaden the population on which we tested on. And in COVID, we've seen that. So most of the diagnostic tests are on people that are symptomatic, but then when you start using it on people that are asymptomatic, and I get it for screening purposes, it may not be as accurate. So it becomes, what do you do in terms of your decision-making on the test result? And one has to be very transparent about that. Even in the setting of COVID, what I would tell patients, even if you test negative, but you feel lousy, you listen to your body. And that's in other conditions as well. So I think we have to also help explain. It's hard to go into the sensitivity, specificity, the positive predictive value, negative predictive value of tests for consumers. But we do need to be more transparent about accuracy and what to do after you get your test results. That's an important point as well.
Excellent. Yeah, thank you.
And they're going to continue to change. That's the beauty of testing. Even, you know, for COVID over the last 9 months, it's been iterative. We've seen improvement in testing technology, even just in 9 months, where, you know, now we have direct-to-consumer tests, we have at-home tests, we have a whole range of tests, and that's innovation and progress, and we should celebrate that.
Absolutely. We just had a question come in. I know you touched on this a little bit earlier, but maybe expand on kind of the regulatory environment. How tightly regulated are devices? If I want to add some basic health monitoring to a watch, do I need FDA approval? Is there accuracy requirement? What does that look like? So
if it all depends whether you want to be considered a medical device. I talked about that. So the FDA does regulate medical devices, and there is some regulatory enforcement. And the head of the group at FDA is a gentleman named Bakul, B-A-K-U-L, Patel, P-A-T-E-L. So he's really in charge of this issue of digital tools, medical tools. So it really depends, what are you going to do with your data collection? How are you advertising it? How are you marketing it? Is it going to diagnose AFib for you? Is it going to diagnose diabetes? Is it going to diagnose insomnia? Most of the tools don't give a medical diagnosis saying insomnia. They may give you a sleep score and tell you what a good sleep score is, but they don't tell you whether you have apnea. They don't tell you whether you have a certain type of insomnia. Some might, but then they need to be careful about whether they are now a medical device. And remember, the medical device, the FDA regulates software. So it's not the platform, meaning it's a device, it's a watch or some other type of tool. That's what the issue goes around. And it's a new administration. So whether the framework will be towards more regulation or less, I think that's something we'll have to wait and see. But just from being at FDA, I will tell you, it's always about, as many of your colleagues know, it's a conservative approach towards risk. And people just have to be realistic about that. We want to make sure that consumers are getting accurate information and things don't go beyond their label.
Mm-hmm.
Remember, 23andMe had to get FDA approval in terms of its certain aspects of what they were testing for, variants in terms of breast cancer and some other areas. And that took a bit of work, and they had to demonstrate their accuracy. They also had to demonstrate that consumers could use this information accurately, could understand it. So there's some hurdles, but then it also opens up a lot more advertising and marketing opportunities as well.
Absolutely.
But I'll tell you, most people don't want to be considered a device by FDA, a medical device.
And what does the timeline typically look like for if you were going?
Usually there's some studies required, and that can somewhat depend on how quick people are willing to put together and what the studies show. You shouldn't assume that just because you're doing a study that it's actually going to turn out in your favor. So sometimes there's no difference, and then that becomes a real challenge to get approval.
Absolutely. And going back to kind of what you mentioned earlier around telehealth, telemedicine, I think you mentioned up to 80% kind of adoption now. Do you see that trend continuing? I mean, I think one of the questions earlier was that a lot of this technology has been around for a while, of course, and COVID absolutely accelerated that.
Yeah.
You see, once doors open again and people feel comfortable, going to see their care provider, where do you see that happy medium? And then how much of this behavior will continue? And then where are some of the technology gaps to kind of push us forward from there?
Yeah, so remember, I said it's about 40 to 50% now in general of visits. It was around 80% at the height of the pandemic. I think where we're going to see is that it's going to vary somewhat by specialty, and I think it's going to vary whether you're a new patient for evaluation or follow-up. I think we'll see a lot more telehealth in terms of follow-up, right? So I've already diagnosed you. You don't necessarily have to come in even for a blood pressure check, which we typically did. I could make sure I give you a very good device, teach you how to do it, and then we can do a telehealth visit even with a lower level practitioner to continue to look at your blood pressure. I think it's the same thing in orthopedics. I may not be able to use telemedicine effectively to diagnose your knee pain, but I could do follow-up visits with you. I could do cardiac rehab and physical therapy through telemedicine. So I think we'll see a lot more in terms of follow-up visits. I think it'll vary more on specialty. We can still do a lot more dermatology by telederm. It all depends exactly where the lesion is. That doesn't mean that you're never going to have to go to the doctor again, because there are things that you need to go to do. But remember, we were able to give people pulse oximeters to look at their O2 saturation. We were able to give people, certain types of stethoscopes that could lead into a device and a tool that I could listen to your heart sound. So I think we'll see a lot more innovation around tools that they can use at home that'll help me do a better physical exam that then won't require you to come in. But Melissa, we have to have payment parity. If there's not payment parity, it doesn't matter if we have all the tools that we could. If we're not going to get paid enough, they're just not going to do it. They can't survive solely on telemedicine unless there's parity.
Absolutely. And I guess kind of looking into your crystal ball, kind of the two sides of the question is, where do you see kind of the most excitement for innovation? And then where do you see the greatest need? Not necessarily always being the same thing, right?
Yeah. And I do have a little crystal ball.
Yeah.
Yeah, I think we have to acknowledge what else COVID has taught us about disparity and inequity. So there is going to be a renewed focus on the social determinants of health that we kind of started off with, that are just not about access to the healthcare system.
Mm-hmm.
And are these two technologies going to exacerbate disparity, as we've somewhat seen with schools, for those people that don't have good internet, don't have the right devices, right? How can you do school on a phone all day as opposed to, a laptop or a computer or a tablet? So I think that's going to be a challenge. Where I think the greatest innovation is going to be in those practical areas that I talked about. I was only partially joking about the toilet, but you can see that concept where it's truly remote patient monitoring that I don't even have to think about, that is going to truly look at preventive medicine over time in terms of even an early diagnosis. Wouldn't that be great if that could tell me if I had pre-diabetes early on? That's going to impact outcomes. I think we're going to see more of that in terms of innovation that's not as glitzy, not as sexy in a way of some tools and resources, but are going to focus on outcomes. And I think that's where we'll see, some of the greatest innovation. I think where some of the challenges are going to be in terms of kind of the standard from before, where if we continue to say, well, we need to build the best and brightest PET scanner and MRI scanner and have the fifth one in this community, that's going to be a challenge. I think there's going to be less of a trend towards more and more hospital wings. I'm not sure that's going to be as necessary as we're talking about how do we provide more care in the home. I think the COVID pandemic has also taught us about the risks of nursing homes. Right now, nobody would want to send a loved one into a nursing home. So I think a great area of innovation is going to be, how do we help people age in place? How do we help them stay in their home? So what are the tools? What are the resources? Where is the innovation that we can help you stay in your home safely? COVID has changed the perspective of nursing home and assisted living dramatically. And that's where I think we'll see a lot of innovation as well.
Yeah, and I'm curious about that too, in terms of, these are obviously, our grandparents, elderly folks who aren't as tech savvy. So how do we kind of get that technology for some of that home health care to actually work? When I'm just thinking about my parents, my grandparents.
Yeah, we say they're not tech savvy, but some of it is, do we really take the time to help teach them? Mm-hmm. Do we really help them learn how to use it? But if you think about a device like Alexa and others, there's lots of things that we could do to empower people at home to stay safe, that they needed to call out. There's some Alexa saying they can listen to your voice, and if you have a certain type of speech pattern, something called agonal breathing, they could alert. I mean, these are still things where we're going to see innovations, but we can have more of that. We can have more voice controlled and voice commands that will enable tech. But it's also talking to people and helping them. I remember my mother was having a lot of trouble with video conferencing a while back in imaging. And what I learned from observing her do it and talking to her is she had bad arthritis. So it was very hard to move the mouse on the keyboard. So it was having a lot of problems with clicks and double clicks and getting frustrated. But I learned using an iPad, and I'm not promoting any brands, all she had to do was click FaceTime and click something else. So I was able to use it. And then slowly being able to learn other things about what digital tools and resources. So some of it is talking to people and really trying to help elderly people learn about it. They don't lose their smarts as they get older, but then also enabling it for some of those issues. Because remember, they're going to have vision issues, hearing issues, arthritis issues. Those are normal parts of aging. So how do we make it easier? And that's the point. So instead of using a mouse, that you just touch it, that you use Alexa, that you use voice commands, that you use other type of devices that can turn things on and off. So it's about innovation and understanding the user. And we haven't always done that.
Absolutely. We actually just had another question come in about the payment parity. What is preventing payment parity for office visits? As you're pointing out, you're not spending less time per patient. So, so what's the deal? Yeah.
Yeah. And I say this as someone who worked at CMS. Imagine that in Medicare. So the perspective is, and I don't agree with this perspective, is that people are going to game the system and they're going to cheat. And I'm going to tell you, on remote patient monitoring, if you read the Medicare policy carefully, they say they're going to have selective enforcement. That means typically they're not going to bother with it until things get, too expensive. And then they're going to start looking at it and try to pare it down. And too often insurers make policies because of bad apples. And they think, you know what, I don't have a lot of ways to truly monitor claims, so I'm going to make them very restrictive. So I think the idea was, well, I'm not going to do telemedicine because the visits aren't equivalent. So I'm not going to pay a lot of money. But what we've demonstrated is that the visits are equivalent in terms of the intensity of the visit, the resources given. I mean, the difference is I also, code it differently based on time and other elements. So that's been the issue, that people don't want to spend a lot of money unless they know the outcomes and they feel it was going to be abused. And there is a concern that remote patient monitoring will be used for people that didn't need it. And sadly, we have a lot of examples where, glucometers and glucose strips were given to people that didn't have diabetes, and they'd have boxes and boxes of strips. So it's, unfortunately, sometimes policies are made to prevent bad apples and not to, empower patients. But I think as we continue to demonstrate outcomes, we'll see that aspect of payment. And sometimes, to be honest too, it's a zero-sum game, and especially in terms of certain payment schedules for Medicare, and how do you balance it? So, and I think that's going to be a change too, to focus on cost savings as well.
Absolutely. No, thank you.
Sure.
I know we're heading toward the top of the hour, and I think I'd be remiss if I didn't ask about just, given all the COVID coverage that has been going on, kind of what's your take on what's next? You mentioned the new administration coming in. Where do you see, I know with the Texas storm, there's been challenges with, getting some of those vaccines out, kind of where are we, and kind of how can we accelerate?
I think we're making progress. I do. And I had an opportunity to speak with the acting FDA commissioner. It turns out my old boss at FDA, Janet Woodcock, just a couple of days ago. And I feel like we do actually have a distribution plan now. I think we had a great development plan to bring vaccines to market, to even bring therapeutics to market, monoclonal antibodies, remdesivir, convalescent plasma, steroids. But we didn't have a distribution mechanism in terms of how to get it out. I don't think there really was a plan, and we've seen that in terms of the slow uptake. So I think we're making progress, but we also have to recognize to, vaccinate 250 to 300 million people in the United States, that's a lot of work, and we're not used to manufacturing that number even of vials and syringes and everything else, and things break down. So I think we're making progress, but we have to acknowledge vaccination is one of the strategies, to crush the pandemic, and we need to encourage vaccination. But we also have this, range of therapeutics. There's over 100 clinical trials on different drug molecules, some repurposed, some new molecular entities. And that's great innovation as well. So I do feel it's still going to be many, many months until we return to a sense of normal or the next normal. But at least now I feel like there's light at the end of the tunnel, whereas I may not have felt that several months ago.
Absolutely. And do you think there are kind of lessons learned from COVID that could be applied to, folks who are developing their innovations right now in terms of public partner private partnerships and things like that?
Yeah. I mean, let's be honest. The reason why all these vaccines were developed so quickly is the government paid for it. And I basically said to you, Melissa, you make this product, and even if it doesn't work, I'll buy it. So I mean, why wouldn't you? I don't know if we'll see quite that, but I think we will see the importance of public health. And let's be honest, most people don't know what public health is. They either thought it was, food assistance for the poor or sanitation. And we're seeing that the public health space and the business world are more connected than anyone thought. And we've seen that because we didn't have a good public health infrastructure, and businesses had to close. So I don't think we're going to allow that again. I hope we don't allow that again. So how does the public health sector work more with the business world to make sure that we develop these tools and these resources and these devices, et cetera, to help prevent this type of, national lockdown. Hopefully we won't need that. More of a, surveillance system that truly is, 21st century. So, I think in that setting, in terms of the importance of public health, I think the importance of innovation that we've seen in terms of vaccine development in 9 months, in terms of therapeutics. So there's a few positives from this, and also the change in the work environment. How more and more work can be done from home, and that's helpful to many people as well.
Excellent. Well, it doesn't look like we have any more questions coming in. I'm sure some folks are definitely interested in kind of learning from this and having some more conversation. I think at this point, we're going to close the official presentation, invite everyone to remain on the call for this extended networking session afterwards. But before we do, definitely, Dr. Whyte, wanted to thank you so much for talking today and sharing your insights on the amazing changing healthcare industry. So thank you so much for your time today.
Sure.
Yeah, I also wanted to quickly remind you that the next Tech Tuesday event will be on March 9th, so mark your calendars, when the Analytics and Insights Forum will present Establishing Data Literacy in Support of Data-Driven Organization. So if you want more information about that, you can register at techtitans.org. Definitely look out for the next event there. Yeah, so thank you so much. I think we're going to move to from the presentation format to the more conversation format now. So you might be able to find out who's in attendance by looking at the names in the chat room or by single clicking on anyone's circular avatar in the ballroom. So once you see that screen, and if you want to change the tables, just double click on the center of the table and you'll move to where you want to go. And then we will close no later than 1:45. But yeah, thank you so much everybody for joining Tech Tuesday, presented by the Health Tech Forum, and enjoy your networking. Thank you, everybody.